Periumbilical pain that radiates to the right lower quadrant associated with nausea is usually pathognomonic for acute appendicitis. More often than not, this presentation would lead to a prompt appendectomy, ideally with complete resolution of symptoms thereafter. However, in the setting of Valentinos syndrome, aptly named after the 1920s silent film star Rudolph Valentino, this is a notorious mimic of appendicitis with potentially deadly consequences. This syndrome occurs when the right paracolic gutter fills with gastric or duodenal fluid in the setting of a perforated ulcer. This leads to focal peritonitis. We present a case of a 48-year-old Haitian male who presented to our emergency room with 2 days of worsening right lower quadrant pain associated with nausea and fatigue. He denied vomiting, denied hematochezia, and denied hematemesis. A CT scan of the abdomen with contrast revealed findings consistent with microperforation with a small amount of free fluid in the right paracolic gutter. Nonetheless, the appendix was not well visualized. Admission labs were notable only for mild leukocytosis of 11.1. Piperacillin, tazobactam, and intravenous fluid hydration were promptly initiated. General surgery was consulted directly from the ED. Within a few hours, he underwent an urgent appendectomy. Unfortunately, he only experienced minimal improvement in his symptoms thereafter and continued to require pain control and nausea control. The operative report detailed an enlarged appendix, however it did not appear inflamed. The patient was unable to tolerate oral intake post-operatively, thus raising suspicion for the possibility of a perforated ulcer. A repeated prompt CT abdomen with oral contrast was performed, and this revealed findings suspicious for duodenal ulcer with perforation consistent with Valentinos syndrome. Given our patient's hemodynamic stability, minimal pain, and benign abdominal exam following this CT abdomen, the decision was made to maintain an NPO status for another 48 hours with conservative management and observation, along with initiating intravenous pantoprazole and continuing antibiotics and hydration. A follow-up upper GI series was then performed, and it revealed marked resolution of the duodenal perforation. The patient was discharged home with pantoprazole and advised to maintain a liquid diet until seen by general surgery and gastroenterology in the office. Additional workup in the outpatient setting revealed negative Helicobacter pylori testing, denial of NSAID overuse on his visit with GI, and denial of prior gastroduodenal ulcers. As expected, intraoperative pathology findings revealed an appendix with no diagnostic abnormality. However, a repeat CT scan done 3 months later revealed no free air within the abdomen, and the patient is scheduled for an EGD soon. Valentinos syndrome remains a rare entity, manifesting with symptomatology similar to appendicitis. Though scarce in presentation, it should remain buried in every clinician's differential diagnosis when evaluating a patient with suspected appendicitis. Fortunately, in our case, our patient had a relatively mild presentation and was able to be managed conservatively without operative intervention. He is now faring well with continued outpatient management.